Hi, everyone, and welcome to Addiction Medicine 101. My name is Mira Grover, and I'm an addiction medicine doctor in Calgary, Canada. I work at a lot of different places, but I don't represent any of those places when I'm speaking here today. This is literally something that I'm doing on my day off that nobody has paid me to do, and I don't know how to make money from YouTube, although I would really like to learn. So if anyone feels like making a reciprocal video that tells me how I could eventually learn how to make money from YouTube, that would be ideal, but I do not have that knowledge at this time, nor do I have the time to learn. So this is just because I think that there's a need. The point of this presentation is to be like a high level thing that gives you a comfort with working with people with substance use disorders. It is not meant to be like a specific medical advice for a specific patient. Um, and the point really of the whole thing is that patients deserve for us to practice at or above the standard of care, regardless of what their diagnosis is. Addiction medicine is a legitimate thing. It's a real branch of medicine, and it has real medical legal consequences for not knowing the basics. I did not learn the basics of addiction medicine in med school or in residency. And so this is sort of to help other people who are in my position feel a little bit more comfortable with working with people with substance use disorders. Okay, so a substance use disorder refers to addictions, right? So an addiction is a treatable chronic medical disease involving complex interactions. Normally, prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. What that means is addiction follows the same pathway as other chronic illnesses like diabetes, like hypertension. These pathways include times when your blood sugars are really good and times when your blood sugars are not so good. It follows similar pathways in the sense of relapse is a common and expected thing. So the goal for treatment of substance use disorder often becomes, how do we space out relapses as far apart as we possibly can? And how do we minimize the harm from those relapses? Ideally, you space out your next relapse till after you're dead. So that is an abstinence-based model. But should relapse happen, it is an expected part of a chronic illness. We talk about substance use disorders specifically because that is the terminology that is used in the DSM-5, and it provides us with practical categories to define and categorize the severity of people's addiction. Addiction has four main characteristics, and that is the presence of cravings, a loss of control over substance use despite negative consequences, and compulsive use. Substances can be used without addiction. So someone might have a glass of wine with their dinner and they don't necessarily have an addiction to alcohol. So when we talk about addiction or substance use disorders, we talk about it referring to these four C's. It's important to recognize that anywhere along the spectrum, from unsafe use on the one hand to complete abstinence on the other hand, might have aspects of both ends of the spectrum. That's why we call it a spectrum. I think that politicians and ideologues often like to pit these two ends of the spectrum against one another. But that's not scientific and it's erroneous. It's sort of like pitting insulin against eating healthy. The truth is, lots of people with diabetes need both. And sometimes they need insulin stat with the hopes of discussions around eating healthy one day. And those are kind of concepts that are really important to embrace here, because especially when it comes to funding models, funding streams typically seem to look at one or the other ends of the spectrum, but medicine needs to look at it as a whole. And that's really important for us to highlight, is that everyone is somewhere along this spectrum, and they're going to have incorporate parts of both. But if people who you are seeing, if patients are further along on the unsafe use harm reduction part of the spectrum, then working or setting goals that are closer to this end of the spectrum are maybe not appropriate. So just something to keep in mind as you approach a patient. We'll just take a quick break and talk a bit about harm reduction. So harm reduction is evidence-based medicine, and it seeks to reduce harms associated with risky behavior. lots of good harm reduction techniques are applied in our everyday lives, right? Like seatbelts. So seatbelts are there because we might not drive safe, or other people might not drive safe, or there might be a landslide that's outside of everyone's control. So we use seatbelts as the norm, just to keep ourselves safe while doing risky behaviors. Insulin for type 2 diabetes is another harm reduction technique. The point of insulin is to prevent acute high blood sugar events, but also to prevent long-term damage from elevated blood sugar. Kind of same thing with statins for people with high cholesterol, or ski helmets. So anything that we do with elite athletes or less elite athletes like myself, uh, we try and keep ourselves safe while we're doing these risky behaviors that we're doing solely for pleasure. It just happens. We want to make sure that, when I go out on the ski hill, that I don't conk my noggin, and that's the goal with ski helmets. Ashtrays, we're trying not to burn down our houses. If we smoke, life jackets when we go out boating. We want to stay alive. So harm reduction can also obviously be applied in an addiction context. Harm reduction in an addiction context looks a little bit different. So it can be supervised consumption. So supervised consumption for opioids or injection substances is a little bit like bars for alcohol. It's a place where people can watch out for you, keep you safe. You're not doing it by yourself. And it's just kind of like a place to use under supervision, use a little bit more safely. Of course, this applies very strongly, especially in the fentanyl crisis and the opioid epidemic that we have here in Calgary right now, where anytime you use any form of opioid, there's a risk that you might overdose because of contamination with fentanyl or carfentanil. So supervised consumption becomes even more important in the context of the opioid epidemic, but it was important before that as well. Sterile needles and supplies, of course, are harm reduction to reduce sharing of bloodborne illnesses. Naloxone kits are a form of harm reduction. Managed alcohol programs are a form of harm reduction. And safe supply, especially in the context of this opioid epidemic that we have right now. Safe supply is acceptable by the Alberta College within the context of COVID especially, and the opioid epidemic. Okay. So supervised consumption sites have been this year especially a little bit controversial in Alberta. But medically, the point of this presentation is just sort of talk about the medicine. So the Alberta government report is not a good form of medical guidance, and the current medical guidelines all actually do support supervised consumption as really important in maintaining, managing overdose deaths and maintaining people's well-being. Okay, so let's get back to what we were talking about, which is where are patients at along that spectrum that we talked about. So the spectrum that goes from unsafe use to abstinence means that in order to get a sense of where a patient is at that spectrum and which direction they're heading, you need to have a good addiction history, and you need to be able to assess their stages of change. So their stage of change will tell you the direction that the patient is going on the spectrum. So pre-contemplation usually means that people are not interested in abstinence only. I think it's really important to get a really good history to assess if there's still, people may be pre-contemplative in terms of ceasing substance use, but they may still want to get to a place where they have safer substance use. So pre-contemplation doesn't mean you throw up your hands and walk away. There are still lots of good interventions that can be life-saving as well as beneficial to the patient. Contemplation means that someone is considering abstinence-based recovery, but they're not quite ready for it yet. And so again, with contemplation, the goal is not just, okay, how do we get them to abstinence right this second? It's how do we keep people safe and how do we medically approach them? So again, assessing both which direction they're going on the spectrum and as well what interventions are appropriate for where they're at on the spectrum. Okay. I'm not going to go through all of the stages of change too deeply. There's lots of good resources available out there. Of course, when someone is maintaining abstinence, we want to talk about how do we do relapse prevention, and we want to focus our interventions much more on building psychotherapy and building the skills that people can use in order to rewire their brain so that they don't have to use substances in order to use to cope. So maintenance phase and relapse, and the maintenance phase to prevent relapse is sort of the key areas to focus our psychotherapy on. Okay, so important to note that as a medical intervention, the most critical thing that you can do with a patient is to determine where they're at on the spectrum and which direction they're heading. And this can be very, very tricky to do. Some patients, because of shame, might say, like, oh, whatever, I don't even want to talk about this, I'm doing fine. Or some patients might be like, yeah, I really, really want abstinence based only. But it's because there's a lot of other factors at play, including like the vulnerability, the fear that they might get kicked out of hospital if they say anything different, um, personal, trying to keep themselves safe, so like self protection. So, all of these things, because patients are human and practitioners are human, all of these things play into this. So, trying to get like a solid sense of where a patient is at can sometimes just take a lot of time and a lot of rapport. It's really important also to make sure that we're always addressing the social situation and helping to reduce some of those barriers to health by advocating for housing and financial assistance and medication coverage. So, as a physician, if I prescribe a patient methadone, but they have no coverage for their methadone and they leave the hospital, and I'm like, well, I did my job, I prescribed them their methadone, that's technically correct, but it doesn't really help the patient. So, we want to make sure that all of these things are in place. And this is sometimes tricky. Like, I remember when I was doing internal medicine residency blocks during my family medicine residency program. The key was always to make sure that you had a good discharge plan, right? So that you things don't slip through the cracks. You have the patients got their prescriptions, they've got their med coverage, they know where they're going, they know where their follow-up clinic appointments are and when they are. So getting all those things teed up is super important, especially for this population, because if you send a patient home with a follow-up clinic appointment, and the clinic is going to call them with that follow-up appointment for like a specialist appointment, if they don't have a phone, then your plan is not going to work. So thinking of these things that are a little bit outside of the box are really important to do. It's also really important to recognize that people's information that's on Netcare or on their chart with Alberta Health Services may not be completely up to date. If someone is homeless and they have an address, and the receptionist is like, "Oh, is this still your address?" It's kind of embarrassing to be like, "No, actually, I lost my housing and now I live in a shelter." So always important to just make sure that you're asking the patient when you're setting them up with clinics and stuff. Okay, so let's get into types of addiction. There are a lot of different substances out there, and I've had a lot of interesting consults where, and rightfully so, not every practitioner is familiar with the different types of drugs that people use and what the side effects of these drugs can be. So, alcohol is a primary addiction that we see a lot of that has a lot of health negative health effects. So, alcohol can include beverage alcohol, which is things like vodka, beer, hard liquor, things like that, wine, um, or non-beverage, which is mouthwash, rubbing, alcohol. Patients don't often volunteer this information, so it's important to always ask it. Tobacco is an addiction, of course, that causes a lot of damage to the body. So important to ask if people smoke cigarettes, if they smoke cigars, if they chew tobacco. Always all helpful things to ask. It's a different question to say, "Oh, do you smoke cigarettes?" than to say, "Do you use tobacco?" Stimulants include cocaine, crack cocaine, which is just a different sort of formulation of cocaine, and meth. Meth is predominant right now in Calgary. It kind of comes and goes. There's lots of other types of drugs as well, but stimulants are basically called uppers in street slang. Speaking of street slang, actually, there's like a million things. There's so many different terms that people use. Tech is very common for meth. Um, And they go in and out of fashion just like everything else. And I have never been able to keep up with daily fashions. And I do not know. So every time someone's like, oh yeah, I use tech, I always say like, is that like, do you mean meth? Or I ask, if I'm not sure, I'll just be like, do you know what's in it? Is it an upper? Is it a downer? Is it like, oh, does it have opioids? Is it meth? Questions like that. Um, and that's how I learn. Cannabis, of course, cannabis can be smoked, but it also can be eaten. It can be used as oils. It also can be made into something called shatter, which is like a highly concentrated form of cannabis that is then uh, made into a different type of substance and can be smoked. And so that's just much higher concentration. So important to ask those questions. There's hallucinogens. And then let's get to opioids. Opioids can be prescription or illicit. Illicit opioids, if someone's like, oh yeah, I buy my oxys on the street, it's nearly always fentanyl. Even patients don't always know that opioids that are illicit are often have fentanyl in them and often have some kind of benzo mixed in too. Um, so sometimes I will offer a urine drug screen if a patient is not sure what's in their substances, just to get a sense, and so that the patient can have a better understanding of what they're taking as well. There are street benzos, so Xanax bars are quite common on the street, and they might be mixed with opioids as well. So always important to not to forget that you might be also looking at a benzo withdrawal or a benzo use disorder picture as well. GHB is a liquid. People drink it, and it sort of acts like benzos and alcohol. And so always have to be aware if people use a lot of GHB to consider withdrawal management. And then there's inhalants, so people huff glue or solvents, and that can cause a lot of problems as well. And then, of course, there's behavioral addictions like gambling or sex or internet. These are really critical when you're looking at discharging someone. You like can't understand something like is missing from the picture. And to ask around behavioral addictions is really important. So I feel like I've said this a lot already, but I'm going to keep saying it because it's so important. A really good history taking is your friend, and it will help you so much in assisting the patient. I learned that in med school. I remember it being like drilled in there, and I remember it being taught all the way through clerkship and residency as well. Is that a good history is so important, and that applies to addiction medicine. And so I cannot stress this enough. People are often more honest when you explain why you want to know the information. So if you're just like, yo, do you use drugs? That's probably not going to be as helpful. But if you say, look, I need to know what you're using. I'm not the police. It is not your responsibility or your right to inform the police if someone tells you that they're using illicit substances. So really important to make sure that the patient knows that they are not going to get in trouble for disclosing to you what they're using. Key things for this are making sure you have a non-judgmental approach and that you don't demonstrate shock at risky behavior. Because if someone's like, oh yeah, I drink 60 ounces of hard liquor a day, if you're like, oh my gosh, 60 ounces, that is not going to win you their trust. There are people who use substances very differently than how I might use them. And that is based on a lot of different factors in their past and a lot of different contributing factors in their present. And it's really important to make sure that we are kind of setting those judgments aside and just getting like a straightforward medical history. So for each substance, we're going to figure out how much do they use. So okay, you use 60 ounces of your alcohol. Okay, do you ever use any other non-beverage alcohol? Is that all hard liquor? Do you also drink beer? Do you also drink wine? How does that work? Then you're going to figure out the method of the use. So with alcohol, it's primarily oral consumption, but let's say people are using meth. Do they smoke it? Do they inject it? Do they both smoke and inject? If so, how often do they inject? How often do they smoke? When did they last use? Really important question, especially when dealing with withdrawal management. So not just like, okay, when did you last put any alcohol into your body? So your last drink was 3 o'clock this morning, sure. But the patient looks really shaky and they're withdrawing really hard. And you're like, it's weird that your last drink was just this morning. So then you ask the question, when was your drink before that? They're like, oh, well, it was 3 days before that, but I got so shaky with my withdrawal. I just had a little bit this morning just to manage it. Okay, so that gives you a different picture and a different timeline and a different sense of what to expect. So just getting that good timeline of use can be really important. It's also helpful to know, like if someone comes in and they're like, yes, I inject meth and I inject fentanyl. And so you just, you're like, okay, well, how long have you been doing that for? They say, okay, well, since I was 15, I've been injecting fentanyl. Okay. What has been your longest period of abstinence? And they're like, well, it was 16 years and I just relapsed last month. Again, this gives you a different picture of what's going on with this patient and a different way that you can assist them. It also helps you to get a good sense of where they're at in that spectrum. Um, it's important to know if people are already within psychotherapy or have recently been in psychotherapy for their substance use disorder, if they've gone to treatment, and then if they're taking any medications. So a patient who comes in who injects fentanyl, but who is on buprenorphine, naloxone, is going to be a different safety profile than someone who doesn't have any OA2 on board at all. The reason we ask about cost again is because sometimes patients are using up all of their money just to stay out of withdrawal. And it again helps you figure out how you can support the patient better. Cost also can lead to questions around how do you finance your substance use disorder, and it can reveal other vulnerabilities like sex work, that's survival sex work and that sort of thing. So important to explore. So some of the red flag things to ask in addiction history. So like chest pain, is this exertional? Is it positional? Like those kinds of questions. That's what we're going to talk about now. So alcohol, any history of withdrawal, seizures, or DTs? Really important question. That is like your number one question for alcohol. Also, you want to know, do they have a history of cirrhosis? Have they ever had GI bleeds? Just so you have a good sense of risk. Opioids. Have you ever overdosed before? Any forms of OAT that you've tried. What are the harm reduction practices that you are currently using? Do you use prescription opioids or illicit opioids or both? Any concurrent benzos or alcohol? That is a super important question. Why? Because benzos and alcohol increase your risk of overdose if they're on board with opioids. So for benzos, how long have you used them for? Oh, I've had them only for the last week during my withdrawals versus I've been using benzos every day for the last 2 years. So any history of seizures during benzo withdrawal, any concurrent opioids or alcohol. For cannabis, it's to figure out if they're using shatter or not. For meth, it's to figure out, does it have fentanyl in it? Have you ever overdosed with just your meth? And for cocaine and crack, also to figure out, is this actually meth? Because sometimes people think what they're using is cocaine, but it has meth in it. And sometimes patients will know that. So good questions to ask. Let's talk briefly about pain management in acute care. So patients with opioid use disorder need more, not less opioids. Sometimes that's like a bit of a mental barrier to overcome, to be like, well, they're addicted to opioids, so I don't want to be giving them more opioids. I don't want to be like the drug dealer or enable them or, all those things. And those are kind of natural things to think about, but it's important to kind of embrace the science, which tells us that if a patient has an opioid use disorder, their tolerance level is different from the tolerance of an opioid naive patient. So if you are trying to treat their pain with opioids, you have to recognize that they're going to need more opioids than an opioid naive patient. There's this huge stigma attached to asking for more pain medication. So many patients will go into withdrawal or suffer. And they would rather deal with withdrawal than deal with the shame of having to ask, and also of having to feel that stigma where people don't understand that they need more opioids than fewer, and are looking at them like they're drug seeking. And that is just a thing that just raises the hairs on every opioid dependent patient, is to feel like they are drug seeking. And that is a harm, an iatrogenic harm that we can cause. So really important to make sure that we are not causing that harm, that we are trying to make sure that these patients are really well managed in acute care. So what that means is scheduled medications plus PRN is better than PRN alone. And just for perspective, like at clinics like the IO clinic, patients might be using 350 milligrams of hydromorph TID. Now, this is a very small subset of patients that are on such high doses, but they still exist. And so it's important to know that there is a big range of how much people can tolerate. And to find out where your patient is on that range, it's a combination of getting a sense of how much they're using in community, asking them, and getting addiction medicine consult help if you're not sure. Assessing community substance use and kind of figuring out an equivalent prescription substance use is very, very tricky. So if you need help with that, ask for help with that. Always have to consider concurrent alcohol and or benzo use in terms of tolerance and respiratory depression. And our primary goal in acute care is to avoid all opioid withdrawal. There's no reason for opioid withdrawal unless literally someone has opioid toxicity, which is an opioid overdose. They are not breathing and we need to Narcan them. And even then, we don't want to be overdoing it. We want to be making sure we're just giving kind of what is needed to maintain patient safety. So if a patient comes in with opioid withdrawal, we do not let them sit in opioid withdrawal in hospital. That's not appropriate and it's not standard of care. Our secondary goal is to manage pain appropriately as well. So you can't manage someone's pain if they're in opioid withdrawal if you're trying to manage it with opioids, right? So making sure that we're managing that opioid debt, and then if people have acute pain needs, dealing with that on top of it. Okay. So let's talk about types of withdrawal that can kill you. Alcohol withdrawal can kill you, right? So when patients come in and they have used alcohol in the last little while and they are planning to stop using alcohol, it is important to do a proper assessment to see if they need an inpatient treatment or not. The pause score can help you decide if someone is safe for home withdrawal or not. If the pause score is 4 or greater, then they need medical inpatient withdrawal management. We often see that patients come to Emerge and get discharged from Emerge because their CWA is not high enough yet. But CWA just gives you a snapshot of a moment in time. So it's like a cross section. So it's like, okay, right now their CWA is 6, so they look fine. But I also know that the last time they withdrew, they were in the ICU for 4 days with DTs. And this time they've been drinking for longer and a lot heavier than the last time. And they're really shaky and their alcohol is still really high. Their alcohol level is really high when their CWA is 8 or 6 or whatever I just said. So then you have to look at, what do I anticipate coming? Is this a patient who can safely withdraw at home? Is this a patient who is likely to come back to hospital if withdrawals get worse? Can I send them to a detox facility, like a medical detox, like Renfrew in Calgary? Is there space there? Do I need to admit them for a few days until there's space there? Those are all questions to ask, and the pause score can help you with that. CWA scores just measure withdrawal as a cross section in time. They do not measure past withdrawal, and they do not predict future withdrawal. Benzo withdrawal. Benzo withdrawal is like alcohol withdrawal. It follows similar pathways in the brain. It also can kill you. The thing about benzo withdrawal, it's not fast like alcohol withdrawal. It's not like a 5-day thing, then you're done your benzo withdrawal. If someone has been on benzos for a long time, it can take months to years to wean them off of benzos. If you're doing a rapid benzo taper, you have to be so careful because people can seize, for those long-term benzos, people can seize up to a month out from having stopped those long-term benzos. So really important to taper very carefully. It's also very distressing to patients and can cause a lot of pain to taper benzos rapidly. So if someone comes in, they have a benzo use disorder and they're using either illicit or prescription benzos, and they are dependent on the benzos, it is important to make sure that we're treating that with benzos as a benzo taper. Okay, stimulants, hallucinogens, tobacco, cannabis, withdrawal sucks, but it's very rarely life-threatening. Symptomatic support is what we do to help with those. Opioid withdrawal. So opioid withdrawal used to be lumped in with stimulants, hallucinogens, tobacco, and cannabis as you don't need medical management for opioid withdrawal. But what has happened recently with the fentanyl epidemic is that people will withdraw from opioids. They manage their opioid withdrawal without medical management. They do not start an OAT. Then, because addiction is a chronic illness where people relapse and relapse is expected, when people relapse, they die because their tolerance is not the same. They even might try and use less than what they used before, but it's still too much. And there's fentanyl or carfentanil in it. So, because that was actually happening so much, is that when people would withdraw and then relapse and then die, there's actually new medical guidelines out there that say that opioid withdrawal without OAT treatment is contraindicated. So, medically, it is contraindicated to allow opioid withdrawal without OAT. Really important to be aware of. Also, opioid withdrawal is very harmful to fetuses. So, in pregnant patients, any amount of opioid withdrawal can stress the fetus and can cause death. So, important to know that. And then Ghb withdrawal, we mentioned this before. It's a little bit like benzos. We just have to watch really carefully and make sure that an appropriate taper and medical management is done. Okay. So let's talk a bit about alcohol withdrawal in acute care. Most acute care facilities all know how to manage alcohol withdrawal really well. The immediate goal for alcohol withdrawal is to prevent seizures, to prevent DTs, and prevent Wernicke's encephalopathy. Internal med is really good at this. ICU is really good at this for really sick patients. So there's not a lot that addiction medicine can offer in this, except for to say that, it's just so important to be thinking about concurrent withdrawal that can happen at the same time. So opioid or benzo withdrawal. And to make sure that we're remembering to try and prevent Korsakoffs and try and prevent that Wernicke's by providing thiamine and folic acid if we need to. Opioid withdrawal in acute care, people are a little bit less comfortable with. Up until fairly recently, opioid withdrawal was an accepted and expected thing that patients would face when they went into acute care for whatever other reasons. But that is no longer medically acceptable. So if you think a patient is in opioid withdrawal, you need to treat it. So you treat it with either OAT, so that's, we're going to get into the different forms of OAT, or you just provide them with other opioids to treat that withdrawal. You can use COWS scores to assist with assessing if a patient is an opioid withdrawal or not. So if a patient scores on the COWS score and they are in opioid withdrawal, then you need to keep treating it until they are not in opioid withdrawal anymore. That's how COWS scores can be really helpful. So it's hard to, like we were talking about before, it's really hard to estimate that opioid debt from illicit substances, but important to know that like people talk about using fentanyl by points. So a point is 1/10 of a gram. Some people might use 5 points of fentanyl a day. Some people might use 2 grams of fentanyl a day. Some people might use 1 point of fentanyl a day. But if we looked at 1 point of fentanyl is about 100 milligrams of fentanyl. Okay, it's not micrograms. In hospital, we measure fentanyl in micrograms because it's so potent. But we're talking about milligrams. So 100 milligrams of fentanyl is 100,000 micrograms of fentanyl, which is 10,000 milligrams of morphine. These are all theoretical things, right? So like we don't have exact opioid conversion. We don't know exactly how much fentanyl is in that point of fentanyl. But just like as a concept, we're looking at massive amounts of opioids. So fentanyl is just way more potent than anything that we can prescribe. The bottom line is that if people are tolerant to illicit fentanyl, you are unlikely to overdose them with only prescription opioids. Most people who continue illicit use in hospital are supplementing because they're not getting enough and their opioid debt is just too high. And so they're going through too much opioid withdrawal. Really important to be aware of that. Another thing to consider is that sometimes we're afraid to go up on opioids to treat opioid withdrawal because a patient might be a bit sleepy. So good to kind of assess all the reasons why a patient might be sleepy and not just blame the opioids. It totally might be the opioids. We all know opioids put people on the nod, but it might also be meth withdrawal, or it might be something else. It might be like worsening infection or like lots of reasons for altered level of consciousness. So part of making sure that we reduce the stigma for these patients is that we have properly assessed all the causes. Um, okay. So OAT, we talk about OAT as treatment for opioid use disorder. So these are things like Suboxone, Methadone, and Kadian. Um, I I will be using the terms Suboxone and Kadian only just because they're easier. Suboxone did not pay me to do this. Neither did Kadian. I'm not actually sure who the manufacturers of them are, but they didn't pay me to do this. But I think it's really helpful for us to kind of talk about these things because they are used in regular vernacular around the hospital. So these Suboxone is the first line OAT for opioid use disorder. Methadone is second line and Kadian is third line. Our fourth line treatment is injectable hydromorphone, which is IOT, and that needs to be done by addiction medicine specialists through an IOT clinic. IOT can also be done in acute care itself and usually follows the guidance of the IOT clinic physicians and nurse practitioners who are available 7 days a week. For as long as IOT remains open. Okay. Let's talk about each of these. So Suboxone. A few myths about Suboxone. You do not need a special license to prescribe Suboxone. Suboxone is not a triplicate medication. You just write it on your regular old prescription pad when you write a Suboxone prescription. You can give out carries. So I usually do 7 to 14 days of carries is no problem. It just depends on if the patient feels like they can manage, they're not going to lose it, that sort of thing. How does Suboxone work? So it's a partial opioid agonist, has high affinity. The naloxone in it, so naloxone is different from naltrexone, two different medications, different drugs. So Suboxone is made up of buprenorphine naloxone. The naloxone part is in it just so that Suboxone can't be injected. Because if you inject Suboxone, you're injecting yourself with naloxone, which unfortunately puts you into withdrawal. So people typically don't inject Suboxone for that reason. The naloxone does not serve any other purpose. It is simply to prevent diversion. So it's really the buprenorphine that's working. So it has a ceiling effect for respiratory depression, which is really protective and very helpful. Patients who are on Suboxone in community should stay on Suboxone in acute care. They just might need higher doses of opioids to manage their pain because the Suboxone might be filling a lot of those receptors already. So you just need like quite a bit more high doses. Again, addiction medicine is always happy to be consulted for things like that. And if you need to initiate Suboxone, the Canadian Medical Association has a really great flow sheet on how to initiate Suboxone. There's a lot of different good resources out there. At the end of this presentation, I will go through, I'll have some links up for people who are wanting to learn more about how to do this. It is very straightforward. I feel like it's less complicated than insulin, but more complicated than prescribing Panto. So it does not, again, need a triplicate. It does not need a special license. You should feel comfortable doing it. If you don't get comfortable, read up on the stuff and ask addiction medicine. Like we're always happy to help. So very, very happy to support with that. There is also a medication called Sublocade, which is like a depot Suboxone. So important to know if your patient is on Sublocade that you would have to treat them as though they're on Suboxone. So again, that means higher doses if you're trying to look for acute pain management. Methadone. Methadone is a full agonist that is long lasting. So it stays in your system for a long time, like up to 5 days after, and sometimes even longer after you've had your last dose. If a patient comes in on methadone, please keep them on their methadone. You could just keep them at the same dose that they had last and consult addiction medicine for any titrating. If you do not have a methadone license, it doesn't matter if you're just maintaining someone on methadone. If you're just keeping them on the same dose, you don't need a special license for that. What you need the license for is to titrate them up or taper them down. It's really important to know that methadone is a daily witness medication for most people. It's important to check and see when the patient's last dose was. You can call the pharmacy because Netcare is not always up to date. And to know that like when we stop people's methadone, we like taper by like 4 milligrams a month, kind of tops. So that's a really slow taper. Please do not stop someone's methadone cold turkey. You will throw them into opioid withdrawal, put them at high risk of overdose and death because they will have to supplement with illicit substances. So we don't want to put patients in that position. We have to be always aware of QTC. So methadone can prolong people's QTC. We need ECGs to help with determining that. If you do an ECG on someone who's on methadone and their QTC is elevated, please ask for help because there are lots of people available to help with that. All right, Cadian is slow release oral morphine. It is third line OAT treatment. It is a 24-hour formulation of morphine. So MS-LON is that 12-hour formulation. So Cadian is different because it lasts 24 hours, MS-LON lasts 12 hours. If you have someone who's on Cadian and you don't have any Cadian in the hospital and you just want to give them MS-LON instead, let's say they're on a dose of 1,000 milligrams of Cadian, that is 500 BID of MS-LON. It would be an equivalent dose for that. You want to make sure that you keep patients on Cadian if they come in on it, just like the methadone. And again, Cadian is typically daily witnessed ingestion as well. The little beads, so Cadian is like a capsule made up of little plasticky looking beads with Cadian inside them, and the beads help dispense the Cadian over that 24 hours. If you inject Cadian, the weird stuff that makes up those beads like slices up your little blood vessels as it goes in, and it can cause massive infections, abscesses, and endocarditis, as well as damage to heart valves. So if you know your patient is injecting and they are at risk of diverting Cadian, consider using fast-acting morphine instead, because if people inject Cadian, it can cause more harm than good. All right. Alcohol use disorder. Let's talk about alcohol use disorder treatment. So first line treatment for alcohol use disorder is naltrexone and acamprosate. Naltrexone and acamprosate are not special drugs that you have to have a special license for. You just fill them out on your regular old prescription pad. So they are not triplicate medications, they're just regular medications. Naltrexone, if you are starting someone on a naltrexone prescription, you have to always be aware they cannot be on other opioids. They cannot have an AST or an ALT that is greater than 3 times the upper limit of normal. They cannot have cirrhosis. You have to be really aware of those things. So if you're sure that those things are not applicable, then go ahead and start naltrexone as your first line. I prefer naltrexone to acamprosate if I can, if they meet the criteria, because naltrexone is once daily dosing and acamprosate is 3 times daily dosing. So I usually pick naltrexone first if I can. If a patient has cirrhosis, and they want abstinence from substance use disorder, from alcohol use disorder, then I would pick acamprosate. They just can't have renal failure because acamprosate is renally cleared. Acamprosate also in Alberta needs Blue Cross special authorization. You have to say why you can't, the patient can't be on naltrexone. Okay. Second line treatment is gabapentin or topiramate. There is much less good evidence for gabapentin or topiramate, but it's still worth a shot if they can't take either the naltrexone or the acamprosate. Gabapentin or topiramate are worth trying with patients, but you have to kind of weigh the risks and benefits and recognize that it doesn't have a huge amount of benefit for everyone. So always an individual decision. Third line treatment would be something like disulfiram. Now, the reason I mentioned disulfiram is because every patient with alcohol use disorder seems to have heard of it. So disulfiram makes you really sick if you drink while you're on it. Naltrexone, acamprosate, gabapentin, those don't make you really sick the way that disulfiram does. So really important to make sure that disulfiram is only for patients who have managed to maintain abstinence. It seems to work really well when you have a partner who is giving it to you, and it's sort of rebuilding that relationship and rebuilding that trust. It doesn't typically work very well when you just give it to patients alone because they just stop taking it if they want to have a relapse. So it can be very tricky, and the evidence around it is certainly very much less good evidence than there is for naltrexone or acamprosate. Okay, other things to touch on. Benzos, we already talked about how we need to carefully taper benzos. Opioids also need really slow tapering. So if someone's like, okay, I've been on opioids a really long time for my chronic pain, I want to come off of them, 5 to 10% per month, right, is like the fastest you want to go, because you want to go really slow so that the brain does not feel like it needs opioids to live. It doesn't feel that desperation that can lead to relapse or illicit use, which can lead to death because of the fentanyl crisis. So always want to make sure that if you taper opioids too fast, you put people at risk of severe consequences with opioid use disorder, or of developing an opioid use disorder. So really important to go slow. Treatment for stimulants, we don't have great evidence. That's the bottom line, is there's not good evidence for medical pharmacotherapy treatment of stimulants. The best evidence we have is for contingency management. Contingency management is essentially forming systems where there is the brain receives rewards for positive behaviors, and whether those rewards are fixed or if they're surprise rewards, doesn't seem to really matter. But contingency management itself is a really helpful thing with stimulant use disorder. If you're interested in that, or you have patients who have stimulant use disorder that you're working with them towards abstinence, definitely learn about contingency management. There are some medications that are tried for stimulant use disorder. I would definitely recommend consulting addiction medicine before trying anything. Okay. So what to do? Referrals for psychotherapy. Sometimes when you don't work in community or you don't work in the field, it's hard to know what the processes that patients face is when they're trying to reach an abstinence-based treatment, inpatient treatment program. So if someone is using and they're in the community, whether they're homeless or they have a home, their first step is often to go to detox. So they might go to Renfrew detox, which is a medical detox. They might go to Alpha House detox, which is sort of medically supported, but not a proper medical inpatient detox. And they might be able to go there for their like 5 or 7 days of withdrawing from their substances. So that just, all detox does is it physically helps you withdraw. Okay. Once you have withdrawn, if you are somewhere like a detox center, then the staff there are able to support by providing applications for inpatient treatment centers and providing information around outpatient treatment programs. So what this means is that you then apply to those treatment centers. You can still apply if you're using, but just often the chaos of using substances makes people unable to make those appointments or unable to get their applications in. So sometimes detox is the best way, but as an outpatient, certainly patients can apply to those treatment centers as well. So ideally, you go to detox, then you get a spot in treatment and you go straight to treatment. But because there is a backlog of places to go and it takes a really long time to get into treatment, often it happens is you go to detox, you then go back home, you don't have any of those new skills to help prevent relapse. So often people will relapse when they go back. Then their treatment date comes up. Everyone's super excited. They have a treatment date. They go back to detox in that week before that treatment date. They go to detox. Then that second time around, they can go door to door to treatment. People will go to treatment, inpatient treatment, and they'll stay there for like a month or so. And that's when they do that kind of higher intensive therapy, especially if it's an evidence-based treatment center. You do that like psychotherapy. You can get like DBT skills, CBT skills, relapse prevention skills, that sort of thing. And then that I talk about that as like intensive physiotherapy. So if you break your leg or you had like a really severe injury and you just have to do like this intense rehab facility, that's what you're doing. All you're doing there is you're working on building those muscles. You're working on building those brain pathways. But if you discharge from that physiotherapy environment and then you just go home and you go to physio once a week and you don't practice those skills every day at home, you are still going to go backwards. You are going to lose muscle mass. And And with addiction, you're going to put yourself at higher risk for relapse. So treatment centers, they set you up with those skills, but they don't help. They don't help you to practice those skills once you get out into the community. And that's another place that we see people relapse, is just after discharge from treatment. So the key is, we are trying to make sure that patients are supported in practicing those skills once they're out in the community. So things like housing, super important for that. Hard to practice those skills when you don't have a house. And groups, right? So things like AA, Smart Recovery. There's lots of different types of groups available to help people with that. So if you chose not to go to inpatient treatment, you could do outpatient treatment. Outpatient treatment is, so you go straight from detox back home, but you like throw yourself into groups, or you do day programs. So these programs are effective if the patient is really motivated and is able to maintain those things. It's maybe a little bit slower in the process because you don't get that kind of initial deep dive, but it's definitely manageable. So it's still doable for some patients who cannot, for whatever reason, attend inpatient therapy. It is always better the more groups you're going to at the beginning, especially, and the more day programs, like the longer, like the more you surround yourself, the better you're likely to do. So that's kind of how psychotherapy works in the city here. Let's talk about a few myths. Patients who ask for more pain medication are drug seeking. That's something that hopefully we have already gone over and you feel comfortable saying that is often a myth. It is really easy to get way higher quality, more potent opioids on the street than it is to wait and emerge, feel like you're being treated badly, feel uncomfortable because everyone's staring at you because you're homeless, and then wish you were just back at Alpha House or the DI and getting a warm meal instead. Like, it's really hard to use emergency rooms or doctor's offices as your place for more drugs. So it definitely happens, but it's just it doesn't make sense for the most part, and it's not common. So important to just be aware of that. We talk about choice with substance use disorders, and I think it's really key to be aware that choice is a tricky thing to talk about. There is an element of personal control, certainly, but as we talked about in the 4 C's right at the beginning, there's a loss of personal control when it has gone to the stage of an addiction. So choice is just very, very tricky. That is not even addressing all the other external psychosocial circumstances. So if someone is out on the street and they are using meth, especially at nighttime, because they want to make sure they're staying awake and alert so they don't get raped while they're out on the street, and you just say stop using meth, that's probably not going to work out. We got to be able to address those underlying factors. Lots of patients have used substances before their brain was fully developed. Lots of patients had dysfunctional families that also used substances to cope, and they did not learn those other coping skills. Some patients might use substances multiple times a day to cope. And so when they're sick and you take away that coping mechanism, you're going to have escalated behaviors. You're going to have people who leave AMA and are not treated. And oftentimes the healthcare system kind of looks at that patient and says, well, that was their choice. But it's important to recognize there's a component of iatrogenic harm that we are perpetuating there. So if we are not recognizing this illness and recognizing the contributing factors and managing what we can do best to address those things, then we are contributing to that. Okay. We again talked about if patients use illicit substances in hospital, they should be discharged. This is not the case. There are some guidelines out there for acute care in Alberta. So substance use in acute care in Alberta, and those guidelines are really clear. And of course, it makes logical sense too that if a patient has a substance use disorder, they're going to be craving substances. And if they're using illicit substances while in a hospital, which happens a lot, they should not be denied care just because of their DSM diagnoses and because they're using illicit substances. We do not do a great job of managing patients' withdrawal in acute care. And this is our way to kind of take responsibility for that and to help out with this. And of course, we've talked about pregnant people and opioid use disorder. If a pregnant person has opioid use disorder and they are in withdrawal, we have to treat it. Okay. Tricky topics. We've already talked about the guidelines that are available. We cannot form patients under the Mental Health Act for their addiction alone. So if you have a psychotic patient because they use meth and they're psychotic and they're running out into the street because they don't realize they're in the street, of course you can form that patient, but you're forming them for their psychosis, right? So you have to kind of be aware of why you're forming a patient. And if you are not sure, always consult psychiatry or addiction medicine and we can help with that. The gold standard for treatment of people with substance use disorder in acute care is that actually they should be allowed to use substances safely in acute care and it shouldn't be a barrier to receiving care. So we always want to make sure we're focusing on unsafe behavior specifically and not criminality. We have this way of talking about people who do things that are illegal where we use terms like criminals or bad guys. But it's important in medicine to remember that what is criminal is always actually in flux based on what societal views and stigmas are. So cannabis was criminal up until recently, right? So now if people smoke cannabis, they aren't criminals, but a few years ago they might have been. So we as healthcare providers really need to focus on what is healthy and what isn't, and how to help all people be as safe as they can be, regardless of what substances they use or what crimes they've committed. So discussions around whether or not substance use is criminal is sort of best kept within forensics. That's not really the role of medicine in that. Okay. I know that I have put forward a lot of themes and concepts that are difficult to wrap your mind around, especially on the first go. Because addiction medicine is relatively new, societal views and administrative views have not always caught up to the science. Really important to decide, am I going to be science first? Am I going to be allow myself to just follow my own biases? So that sort of fluffy parts of med school that we sometimes glazed over during med school, that was certainly me. So I don't blame you if you're going through that right now. But what I found is that that's really critical to patient care. So it's important to go through that and evaluate your own biases. Part of that is also to make sure that you are always using medical, person-centered, non-stigmatizing language. So you say, this is a person with severe opioid use disorder. So we're using medical terms to describe a medical illness. None of us want to be biased, but you know what? The reality is we all are. Elite athletes who present with repeat injuries are just not treated the same as people with alcohol use disorder who present with the same hepatic injury. These social and structural stigmas are deeply entrenched. So part of our job is to help name them and to advocate for good care. It's really helpful to consult Addiction Med with that because we've had to work through some of those things ourselves in order to get good at addiction medicine. But I think the biggest thing here is sort of being willing to keep learning and to keep growing. Probably in a week, I'll look back at this video that I've made and be like, ooh, I use such stigmatizing language. Why did I say that? Why did I do those things? I need to change that, When I started in this field, I used terms like addict or clean needles even all the time. Now I try really hard to say sterile supplies instead of clean needles because there's that assumption, right? That if you have had this needle in your body, then now it's a dirty needle because you're dirty. People feel these things. They feel them when you say them. So I try really hard to work on changing my language, and I'm constantly being challenged in this and constantly getting it wrong and then learning and I keep on trying. When I look back at things that I've written previously, even I feel embarrassed, but I also feel motivated to keep trying to adapt to new learning. So it's not like you have to be hard on yourself, like, oh, I used the term addict in my last thing that I wrote. It's like, yeah, that wasn't good, but I didn't know that it wasn't good at the time and I didn't do it intentionally. And I'm not going to keep doing it moving forward. Move on. So that's sort of how I approach that. And I think that's all we can ask of one another. You always want to make sure that your care is really evidence-based and patient-centered. So making sure that you are aware of where the medical guidelines and your personal opinions might diverge, and then deciding that when you have your doctor hat on, what are you going to do with that? And if your personal beliefs are not in line with the medical guidelines, think about why. Really important to take a good time to assess why you think the things that you do and to get a sense of how to bring these things in line. Um, and of course, consult addiction med. I feel like I said that a million times. Consult addiction med. We talked, I think on one of the slides, there's the rapid line. So you can call rapid for help with opioids management. And that's like 8 a.m. to 8 p.m., 7 days a week for Rapid South in Calgary. Okay, important guidelines to know. I remember going through the Hypertension Canada guidelines for my CCFP exam. That was brutal. Those were so long. So are these. These are also long, but it is as important to know them as it is to know the Diabetes Canada guidelines. If you have a patient who has hypertension, you should know what the standard of care is and what is expected of you. If you have a patient who has a substance use disorder, you should know what the standard of care is and what is expected of you. The hard part is that I had time in med school and in residency to learn those things. And now I'm in practice and I don't have a lot of time. And I know you don't either. But you didn't learn these in school. You got to learn them at some point. So there's lots of CME credit courses that you can do for these and to go through these. But it doesn't matter that you are busy or that you didn't learn these in med school. Medical legally, we're required to know them because we all have to kind of follow them. So really good guidelines to know. Resources for further training. So there's courses that you can take to learn more about opioid use disorder, about how to prescribe Suboxone, how to prescribe Methadone, how to prescribe Cadian, and you do not need to be a specialist. This is the PACES website. If you go through that, you can get your Methadone license, but you don't have to go through all of it. You can just look at the sections that you want and just not get your Methadone license as well. So it's these are all free and they're available. I'm not going to talk too much about COVID-19 and the specifics of substance use disorder and addiction in this pandemic, but I will say that I work nearly every day and I don't get a lot of time off and I'm exhausted, and so are all the other addiction docs that I know, because the pandemic, as any health crisis that we face, disproportionately targets marginalized individuals. And we see that people who have concurrent substance use disorders do have a disproportional risk level. So just really important to, again, if you are coming across patients with substance use disorders, even in the context of the pandemic, all of this stuff that I've gone over becomes even more important and even more critical to look at. Okay, I will stop my screen share for right now and you can actually see my face. I don't really know how to use Zoom or YouTube or videos, so this is the best that I can do. I have done this Addiction Medicine 101 session in various formats and like with different tweaks for different groups in the past. This is meant to be a generalized one. I know it is a little bit acute care heavy, and that is probably because of the COVID pandemic and because a lot of our patients are ending up in the acute care right now, and so they just need a little bit more of that. But I hope it has been helpful. If you have any questions about any of the topics that we've covered in this, or you have any patient-specific questions, talk to your friendly neighborhood addiction medicine specialist. We're all pretty friendly, and we all are able to kind of cover all these things because these are fairly basic concepts for all of us. So speak to any one of us who consults in hospitals or the Rapid line. Okay, I hope this has been helpful.